Everybody, I'm going to get this started. We're going to talk about healthcare delivery systems, and we're going to talk about insurance and billing and coding and all of that kind of great stuff as we start into this next unit. I know you guys are working on a couple different things, but we're going to be working through healthcare delivery systems. And once again, I'm sorry I wasn't here last week. I was out with a back injury, and so hopefully we will be back running smoothly starting this week. Alrighty, so healthcare costs, prospective payments system is what our how our healthcare is paid for. Many years ago, before DRGs, which is basically how they group different diagnoses. Before DRGs were there, people were paid by the visit. So prior to about late 80s, early 90s, you were paid for paid by the day in the hospital, paid by the visit for home health, paid by the doctor, for a doctor's visit by the doctor's visit. The doctor could have you come in once a week, or 5 times a week for some kind of treatment, and he got paid for every time you were there. Well, what happened is the cost of healthcare started skyrocketing, and people were abusing that system. So in the early 90s, they developed a system called DRGs. DRGs are diagnosis groups, so diagnosis relevant groups. So if you have pneumonia, they figured out if someone has pneumonia, this is what it should cost to take care of them in the hospital. And this is what should cost to take care of them at the doctor's office. And this is what should cost for them to be taken care of if they need home health. Or if they need physical therapy. There's a set amount of money that's paid. Now, I can tell you, I'll give an example of how DRGs work in reality since 1991. So when my daughter was born, my oldest child was born in 1991, that was right about the time they were changing from day-to-day payment for the hospital into the DRG process. So day-to-day process, I had a C-section, a cesarean section with my first child, and I was in the hospital 5 days. She was born, actually I was in there 7 days because I was in labor for 2 days, but I was in the hospital as a patient after she was born for 5 days. Now, I didn't run fever. I got up and around like I was supposed to. My daughter was fine. There were no complications with her. But I stayed 5 days, and the hospital got paid X number of dollars for every day I was there and for every day that my daughter was in the nursery. So they were getting 2 separate payments. Now, let's jump ahead to 1996 when my son was born. When he was born, I had a C-section, and he was born very early and was in the hospital for about a month. But they released me, and I had a C-section, a gallbladder removal, a cholecystectomy, or my gallbladder removed, and a tubal ligation, or my tubes tied, all at the same time. So I had basically three procedures. I was in the hospital. He was born on the 29th, and I was home New Year's Day. So with all of those things I had going on, and with him being in the condition he was in, being on a ventilator, and all those kind of things, they discharged me, and he stayed in the hospital. Had that happened in 1991, they would have kept me in the hospital with him for that time. So they discharged me home, and then I just went back to the hospital every day for as long as they would let me, and I would sit with him and that kind of stuff. But the difference was the amount of money they paid was based on, now they keep you 2 or 3 days after a C-section, and you at least 3 days after a C-section now, and about a day or two after a natural birth. And that's because it's paid for the pregnancy and the whole pregnancy, and the delivery of the baby is all under one DRG. So used to, you got paid for doctor's visits at the OBGYN. Every time you went in, the insurance company would pay the doctor, and then they would pay for the delivery, and then the hospital got paid also for all the services there. Now the doctor, the OBGYN that delivers your baby, gets one lump payment for what's called a global payment, gets one payment for the entire time you're pregnant and for delivery. And then the hospital gets whatever DRG is for for a C-section delivery. So it kind of capped off the astronomical or the inflated rates at which things were being paid. Also, prior to then, we didn't have what's called managed care or health management organizations or HMOs. Managed care basically means that everything that happens or everything you do besides seeing your primary care doctor has to be approved through the insurance company. When I first started doing healthcare, where I had to actually interact with insurance, was about 2007. Prior to that, the years before that, I was a nurse. I worked in the hospital. I had not, so I didn't really, as a nurse, didn't really deal with a lot of insurance stuff. Just making sure my documentation was good. But when in about 2007, I started to deal with Medicaid. We'd have to call Texas, Texas Medicaid, and we would have to ask them for permission for a certain number of visits. If I could give, and I talked to a nurse on the other end of the line, and I talked to a person, and if it was something I could justify the patient needed, it was no problem getting extra visits, getting swallow studies, getting whatever they needed, transportation, whatever they needed. About 2010, 11, 12 that year, between those years, Texas Medicaid went from being run by the state of Texas to being a managed care program where everyone who had Medicaid, depending on where you were in the state of Texas, you had to choose one of 2 or 3 different insurance companies who managed your Medicaid. So basically, Superior, Amerigroup, Molina, Cigna, and United Healthcare are the 5 companies that kind of service all of our area around us. And so depending on what kind of care you needed would depend on kind of what program you chose. But everything that we did, including the initial assessment for a home health patient or the patient going into the hospital, we had to get approval immediately or within a 12-hour period, or the hospital or the facility didn't get paid. So we had to do prior authorizations, which means getting the service pre-approved. That's what prior authorization means, getting the service pre-approved. We had to do that well in advance, or as far in advance as we possibly could. And sometimes it may take them a week or 2 weeks to get a patient an x-ray or an MRI or a CT scan. I've had patients wait months to get some services. So managed care can be good because it can lower the cost, but also it can be difficult for patients. So let's talk a little bit more about that. Was the insurance portion. Now let's talk about the levels of healthcare. Preventative care is a big thing, and as you guys get older and you become adults and you get insurance, or your families have you insured as you get older, preventative care is going to be a really big thing. Insurance companies are actually going to reward you in the future and reward the physicians as well if you take care of yourself. So preventative care, like going in once a year for a checkup, getting your eyes examined, going in and just making sure you're healthy. When you're at a certain age, if you need mammograms or you need your prostate examined, or maybe you need specific blood work, thyroid panel, just going in once a year and getting that done, that preventative care prevents you from having multiple visits to the primary care. It keeps you healthy longer. The doctor, if you go in and maybe your cholesterol's a little elevated but not enough for medication, them instructing you on diet, and then you being proactive and eating the way you're supposed to lower that cholesterol level. Primary care is what we think about when we think about going to the doctor. So our family physician, the doctor's office, that's primary care. That's where we go for all of our aches and pains and flu and minor sicknesses. Now, that's what primary care basically is. It's the person who is the primary provider for your outpatient care. So, let's see, in the Sulphur Springs area, some of the doctors that do primary care are Dr. Balcom. For kiddos, it might be or Dr. Balcom, Dr. Cutrell, Dr. Horn, they're primary care providers. In the pediatric, it's Dr. Connor and Dr. Forster in the and Dr. Barclay in the Silver Springs area. In the Paris area, you might see Dr. Cutrell, which is the other Dr. Cutrell's brother. You might see Dr. Bircher. You might see Dr. Gibbs is another pediatrician. So you may see a pediatrician, you may see a primary care doctor, but that would be your primary. Secondary care would be like in the hospital. So that would be when you get sick and you have to go to the emergency room or minor emergency, something that's a little higher level of care. Or day surgery, those kind of things would be your secondary care. Tertiary care is going to be more intensive, like ICU, longer term care, step down units after a hip surgery where you're staying there a little longer for continued care. Long term acute care facilities are called LTACs. Long-term acute care facilities, those would be considered tertiary places where once you've been released from the hospital, you go there for a certain amount of time to kind of, you don't need that intense care, but you still need maybe IV therapy, or you need wound care, or you need things to go on, but that can't be done at home. Or can't be done at a rehab facility, but they need that higher level of care. So that would be tertiary care. Restorative care is what you guys think about when you think about maybe rehab after a hip surgery, when someone goes to the nursing home or a rehab facility like Kindred Care for either 14 days or 30 days, or sometimes up to 99 days for restorative care. And those people are there to get themselves back in a condition where they can go home. Continuing care would be things like the nursing home, assisted livings, home health, or hospice. That would be continuing care. That would be care once the person goes home from that restorative care, or they move from like an LTAC to a nursing home for that continued care because they can't be at home anymore. So that tells you a little bit about the levels of care. And we're going to talk more about preventative and primary care settings. So school health services, occupational health services, those are places that are going to do preventative care. Your doctor's office, clinics, nursing centers, block and parish nursing. We see those like in places like Louisiana. Block and parish care nursings are sort of like what we consider the community health clinic or public health clinic. That's what that would be. So that would be where the preventative and primary care settings. Preventative care, like I said, it's you going in and maybe at school they check your vision. And if your vision's less than what it was before, they'll notify your mom. School health checks for scoliosis. If you're sick, you're going to go in there and they're going to send you home. Occupational health is a little bit different. Occupational health has to do with safety. They deal with immediate injury. They instruct on like proper lifting, taking care of your back, taking care of your legs, other job-related safety. They may do yearly blood work for you. They may have what they call a yearly health screening, where they may do blood work and EKG, because I've done this for a couple of places when I worked in Silver Springs. We did blood work, we did height, weight, blood pressure, those kind of things, and we sent that information to that patient's doctor, and that served as their kind of like their initial checkup, and then the doctor would call them if they needed to come in. Or you can do that, like I said, at the physician's office. Sometimes there are community clinics. We don't see quite as many nursing centers here as we do in other states. They'll have, and especially if you were in some European countries, a registered nurse like I am would actually have her own office like a nurse practitioner does here. And then, like I said, those block and parish nurses or nursing are going to be like the public health clinic. Secondary and tertiary care settings are going to be, like I talked about, hospitals, medical centers, emergency departments, just medical units, intensive care. Going to be places like psych facilities, rural hospitals, which you're in the part of Texas we're in. That's about all we have are rural hospitals. And if anything is serious, they're sent to another higher level of care facility, outpatient therapy or outpatient services like physical therapy. That kind of stuff. And restorative care, so that'd be home health, rehab centers, extended care facilities like LTAC facilities, those kind of places. Those are going to be places that are going to give restorative care. Continuing care agency on aging. So that is a facility. We have an area agency on aging in Texarkana. Nursing home, assisted livings, adult daycares, hospices. Those are going to be that continued care setting. Issues in healthcare delivery. So sometimes, depending on where you are and what's going on, we have to make sure, one of the things we have to make sure is that whoever's providing that care is competent, that they are providing care that's within the scope of their practice. As a nurse, I can't interpret lab results for you. I may know what's normal and what's abnormal, but unless the doctor has given me a note of what to tell you based on my license, I can't interpret that. I can't diagnose patients. I can do something called a nursing diagnosis, but that's very different than a medical diagnosis. You have to make sure that the practice that's being delivered is evidence-based practice. So you'll find as you get out into the healthcare world that there'll be doctors who are very old school, and it's a lot of trial and error with them. Not that medicine is not trial and error, but there's very specific evidence that studies show us how to improve care, to do what's called best practice based on a diagnosis. So, best practice based on someone who has had a heart attack. Best practice, the American Heart Association says that someone who is post heart attack, we want to keep their blood pressure on the low side because they've had a graft and we don't want it to mess up that graft of vessels. They need to be on a beta blocker, a calcium channel blocker, and they need to be on a fluid pill or on a diuretic. So that's standard protocol, plus putting them on a 2-gram sodium diet and doing cardiac rehab. That is the standard practice, and getting them up and moving as quickly as possible. 40 years ago, a patient would have had a heart attack, and if they were able to do the graft, they would keep them in the hospital for 6, 8, 10 weeks, 12 weeks even, and we don't do that anymore. Also, an issue in healthcare delivery is sometimes knowing the patient. So we need to know that patients have different needs. Their needs are based on culture. Sometimes they're based on faith. Sometimes they're based on financial availability. So we have to know, as healthcare providers or healthcare support personnel, what our clients are able to do. If I have a patient who lives on a fixed income and they're in their Medicare gap window on their, or we call it a donut hole, but their Medicare D, which pays for their prescriptions, there's a window of money that they have to pay for all of the whole cost of their prescription. Well, I need to know that my patient can't afford their medicine in that window, so I have to do my best to give them lower cost medicine, so maybe they don't meet that window threshold, or I find ways around it. Or maybe I could give them a $4 medicine instead of a $400 medicine. You have to make sure that the people are working there are licensed. When I first started working in healthcare, nurse aides, we could just train on the job. Medical assistants could just be trained on the job. They didn't have to go to school. They didn't have to be certified. Those things have changed. Another is the quality of care. How did they do on their last survey with Medicare or with Joint Commission or one of those places? We want to make sure that people who are given care are doing it based on best practice standards. Client-centered care. This is something that all healthcare is moving to. Patient care centered home. Basically, where we try to do the most we can to give you care that is respectful, that we understand or do our best to understand each patient's values, their preferences, and that patients can feel that we respect them enough that they can express their needs. We can't judge patients. If you're a judgmental person and you look at someone before they even open your mouth and you make a judgment, and based on the way they look, you decide how you're going to treat them, healthcare is not for you. You will treat, as a healthcare provider, healthcare professional, you will treat every kind of person from every walk of life. And you have to know that your job is to be respectful to them and to do everything that you can to help them. You have to be able to coordinate care. You have to be able to make sure that once you coordinate that care, that it's actually taken care of, that coordination and integration. When say that you have a patient who is a 68-year-old retired living on Social Security of about $800 a month. After Medicare and Medicare D payment comes out, they get about $800 a month, and they need a CT scan. Well, you've got to know where to send them so that Medicare pays the most amount, because they have to still pay 20%. So you don't want to, if you can send them to a place that a CT is $400 instead of $4,000, you're going to make sure that you send them to that appropriate place. And then you have to make sure that those results get back and the patient is contacted. You have to be sure that a big part of healthcare is education. Education, talking to your patients, making sure they understand the information. It's really hard sometimes as a healthcare professional. We're so used to charting all these big words and saying all these big words to the doctor, or the doctor saying them to the nurse, or the doctors talking to each other, or nurses or medical assistants talking to each other. We use these big words, but we have to make sure the patient understands them. And we have to make sure our patients are comfortable. We don't want them to walk into a room where the light is too bright and they're cold, and it hurts them to sit in wherever we have them sitting. We want them to be comfortable. Because if they're comfortable and they feel respected, they know you know what's going on with them, that you followed up and that you've talked to them. They're going to do what you ask them to do when it comes to improving their own care. We have to be emotional support. We do. We have to calm patients down. We have to tell people things that are really hard sometimes. Sometimes we're sitting there for emotional support. Sometimes we're the one giving them bad news. It's very difficult, I can tell you from personal experience, to have to go out with a physician, as a nurse, go out with a physician who did not like to tell people their family member had died, and be the person who's telling that family in the waiting room, I'm sorry, your family member has passed away. You don't want to do that when someone's alone. You want to make sure that you call. You say, can I call someone for you? We need to talk, but I need to make sure that that there's somebody here with you. Just kind of those things involving family and friends as much as the patient wants. The worst thing you can tell a patient, and every patient's experience is different. Every patient's experience is different. I can give you examples of things I've had to do and how difficult they were, what I've seen. But the experience of taking on your first patient death, is different for everyone. Just like finding out that you have cancer, that you're terminal, that someone has died. It is different for every person. So please don't tell them I understand. You can say, I'm sorry. You can say, is there anything I can do to help you? But don't tell them you understand. That's not respectful to the patient. Just tell them, I'm here. What can I do to help you? Sometimes it's just sitting next to them and not saying a word. Also, when we move people, this happens a whole lot. Patients will go from a hospital to another hospital to a rehab facility and back to the doctor once they get home. So sometimes that transition of care, it may go smoothly in one or two places, but then someone drops the bucket. And that continuity of care, the continuation of care, the transition from one place to another, and the continuation of care. That's what that means. Transfer and continuation of care. Transfer and continuity. Transition and continuity. That means transfer of care from one place to another. Continuity means the continuing of care. And the patient understanding. We have to make sure that that's smooth. And you have to be proactive in that, which means if you are working in a doctor's office and you know your patient, the doctor sent your patient to the hospital and you haven't seen them in 3 months, or you haven't seen them in 6 weeks, you got to go back, and they've got an appointment tomorrow. You got to track back and figure out where that patient's been and get those medical records. So when the patient comes tomorrow, the doctor knows what's going on. Or if you're the doctor, you know what's going on. Because that also makes a patient have less faith in your ability if you don't know what's happened since they saw you last. It is your responsibility. Now, it's also the responsibility of those facilities to send that information to each location. But sometimes you have to be proactive because sometimes that continuation of care will fall off and because a smooth transition didn't take place. All right, guys, that is it. We're going to talk about insurance and a little bit about billing and coding, careers, things like that next. All right, so you guys, I hope you have a wonderful day, and I will be back with you tomorrow. Okay, thanks, guys.